very warm welcome and good evening to all the speakers, panelists, and all the delegates who have logged in for today's webinar, Imagine 1.0. As you all might be knowing, JOS is one of the most vibrant and active ophthalmology societies in the country, conducting regular academic activities and live surgeries throughout the year. Many of its members are academicians of national and international repute, and not to mention the ever-increasing participation in the AIOS leadership also. Unfortunately, during the present pandemic, all the physical meetings have been stalled and we don't know for how long. Nevertheless, academics have to go on and virtual meetings are the best way for now. So in continuation with the webinars JOS has been conducting, we present Imagine 1.0. The theme Imagine is based on showcasing what's new in the field of ophthalmology. It may be related to therapeutics, diagnostics, or any part of our specialty. The theme also includes indigenous modifications of the commercial products which were already present in the market and now have been modified by our colleagues to suit our need. This is the first of many such Imagine series planned by JOS. I feel privileged to welcome our esteemed speakers, Dr. Rajeev Raman, my teacher and senior VR consultant, Shankar Nethralaya, Chennai, Dr. Raju from Bangalore, Dr. Sumit Khanduja from Karnal, Dr. Arun Kshetrapal, our own JOS member, a very dynamic ophthalmologist, masterclass innovator, a prolific surgeon, and above all, a great friend. I now welcome our president, Dr. Virendra Agarwal, to start over the proceedings. Sir.
Thank you, Vishal. And I'm really happy to have the very dynamic secretary and executive team of JOS who are working hard during this corona time also to bring all new such sessions. And I welcome the guest speakers also. I am very impressed by the machines to imagine the eye. But first time I want to say it is a very good talk that you should record all your surgeries, all your procedures, or your cases who are not unique or who are unique, to present it to others, because we are learning in this time by virtual meeting only, and all your recordings can do a good teaching to others. And we have the best of the people who have mastered their skills in surgery also, but they are having a good recording and they are going to guide us how to do a better recordings of our cases during surgery and during OPD. So now I hand over my permission to Vishal for taking the session forward and invite the speakers.
Ritesh?
Yes.
You can now call on the first speaker and just introduce him.
Good evening all. I welcome you all on behalf of Jaipur Ophthalmological Society. It's my privilege to invite Dr. Rajeev Raman sir first. I'm just trying to concise about his achievements out of his 40 pages CV because it is not possible to speak all due to paucity of time. Dr. Rajeev Raman sir, after completion of his MS and DNB, did VR fellowship from Shankar Nethralaya, Chennai in 2002, and after that he is giving his services as VR consultant there. He is also visiting professor at Anglia Ruskin University, Cambridge. Apart from ophthalmology, he has done various courses in computer applications, research methodology, and advanced cardiac life support. He has worked as reviewer of various prestigious Indian and international journals of ophthalmology. I invite him to give him valuable talk on Brolucizumab in management of wet AMD. Welcome, sir.
Yes. Yeah. So I would like to thank Jaipur Ophthalmological Society for such a good initiative. I saw the agenda and really a nice agenda and covering all the recent aspects. And next couple of minutes, what I would be sharing would be about a drug which has just now released in India, Brolucizumab, and the role of Brolucizumab in management of neovascular AMD and how we can translate the evidences to the clinical practice. We don't have any experience of this drug today, but as I have told that already in India, it has been launched as Pagenex, and we'll soon, all of us would be using this drug. So neovascular AMD in India has really, we have seen many players in the market. It started with bevacizumab, Avastin, and always this fear of endophthalmitis, off-label that was there. And then ranibizumab has robust evidences, lot of clinical studies which have been done, and more so, it has an India-centric special costing. It's one of the cheapest throughout the world you get in India, ranibizumab. So definitely that's something which we have been using for a couple of years now. And once the patent of the drug expired, we also started having the biosimilar market. And today we have Razumab, many more in pipeline. However, initially there was fear of inflammation. There were a good number of cases who had inflammation, and company did some measures, and now we don't see those inflammations much. And it is a good alternative to ranibizumab. However, in clinical practice, many a times we don't use it as an alternative to ranibizumab, but as an alternative to bevacizumab. Aflibercept is an important drug showing very good promise in neovascular AMD and other retinal vascular diseases. However, the cost of treatment is a limiting factor. It has definitely found a place in India, especially in treating cases who have these fibrovascular pigment epithelial detachments and polypoidal choroidovasculopathy, where PCV, nowadays, many of us, we use it as a first-line therapy. PDT, which was much before these anti-VEGFs came, definitely it has a place even today in managing PCV. However, the biggest problem we all have is availability. At some time, many of us had these machines, but now there are only few machines in the country which keep on rotating, and definitely cost is a factor. So with this market in place, now we have another drug. And before talking about drug, how we treat these patients, the treatment strategy in neovascular AMD, to get the best benefit in terms of visual benefit as well as treatment response, currently what we try to follow is a treat and extend regime. That is, you extend or reduce the follow-up with injection at each visit. So you start with a loading dose, and after the loading dose, you see if there is no activity, disease activity, you extend the retreatment interval by 2 weeks. So make it 6 weeks, then increase by 2 more weeks till 12 weeks, that is 3 months. So that's one way. And in between, any time you feel that there is a activity, you reduce the retreatment interval by 2 weeks. This seems to be one of the good method of managing neovascular AMD. And they say that it gives similar visual gain like monthly treatment. There is less number of injections, minimum occurrence of a new fluid, which is a sign of activity. Also, because less injection, less risk of injection related side effect, and it to somehow it minimizes the cost. However, in our clinical practice, when we start treating AMD, we all want all our patients should be treated with treat and extend. And we start with this, we extend the follow-up and treat, and at some time, he starts having that pinch that no, every time there is an injection, number of injections are more, and that is a time we shift to PRN. Meaning, PRN is a regime where you start with a loading dose, and when you get activity, some predefined OCT criteria, mainly presence of fluids. The moment there is a fluid, you inject it. However, we make it sure that he comes every month, especially for the first year. Now, this again helped because to some extent that the injections, not every time you need to give, but the number of visits were nearly the same. And again, patient has problem whenever we start. So we start with ideal, go to a little better one, but many times even this doesn't suit because every month he's unable to come. And in clinical practice, sometimes we tend to go to what is called as wait and extend. So what we do here, once the activity is not there, we increase the follow-up, but we don't treat it. So a mixture of PRN and treat and extend is something we practice in our daily, whenever we treat neovascular AMD. You imagine a patient who had 3 loading doses and there is no activity now, and it remains like that for 1 year. And let's see that what happens if you follow all the 3 regimes. So if you are doing a treat and extend, you inject 7 times in a year and call him 7 visits in a year. If it is a PRN, you inject 3 times in a year and call him 12 times in that year. And if it is wait and extend, you inject thrice and you call to the hospital 7 times. So definitely this is what in the clinical practice we are doing. But again, there is a lot of evidence that the less you give the injections, less number of visits is a problem. So this is a real life data of multiple countries. So it's not only India. You see all other countries also, in a real life patient don't take regular injections. In Germany, Italy, it's hardly 5 injections in 2 years data. So it's the same situation even in our country. And what they found that initially there is a good improvement. Over a period of time, in 2 years time, the vision definitely declines. So you don't sustain that activity. And that means if you reduce the number of visits, there is always chance of missing on activity. And if you reduce the number of injections, you get a suboptimal outcome. Now, what is optimal outcome is you have a membrane and everything goes away. That's the ideal outcome. However, when you do this under treatment, sometimes fluid may go away, but you end up with a fibrosis. And if you over-treat it, now we have a fear of what is called as atrophy. So I think a proper balance as far as the treatment with anti-VEGF is needed. So 100 million question is like, who decides which drug and which regime to be used in a patient? And it is the patient who decides. Though we always think that the doctor is the one or pharmaceutical decides sometime, but it's the patient. And there are many factors which govern it. The awareness about the disease, the realistic expectation. Many times they just feel that it's a magic drug and they will return back a perfectly normal vision, the cost of visit, cost of treatment, other comorbidities, family support, the fear of travel, especially in COVID times, the fear of injection. One bad experience of anti-VEGF injection, it will drive him off and he will never come back to you again. Or any previous bad experience, these all play a role. And that actually decides which drug to use and which regime to follow. And just coming to disease, there are 3, what I was talking about, disease activity is usually judged by these 3 parameters. Presence of fluid, subretinal fluid, which you can see here. I'm not able to put the pointer, but again, presence of intraretinal fluid and presence of sub-RPE fluid. Now, then again, these fluids we have started recognizing very late, even now, but we've been mainly looking at change of thickness. So if you look at many of these trials, the landmark trial, Anchor, Marina, View, CAT, and Ivan, all of them, they actually looked more into the change of thickness, though the retreatment criteria was presence of fluid, but they never categorized these fluids that whether it's an intraretinal or a subretinal, they just said presence of fluid, treat it again. And the reason being that all these trials actually used a time domain OCT. If you remember when the OCT came to India and we all started using it, this was the earliest machine with a very poor resolution, no registration, no image averaging. So a lot of problems of this machine, but all these trials had used only time domain. Though they could say that fluid present, and they did say that whenever the residual fluid is present, usually it is associated with a poor outcome. And the current OCTs, we know the spectral domain OCTs are now much better instrumentation. They have better resolution and they actually can look fluid in a more detailed manner. And there are only these 4 or 5 trials, the Harbor, Hawk and Harrier, which I'll be talking about, and few trials with another drug called as Epicipar. So these were the only trials in retina who have a spectral domain OCT. So let's see what is bad for the vision and what is bad in terms of neovascular AMD. Initially, the concept was that it's the retinal thickness, more poor vision at the end. But now it is realized that it is the central subfield thickness variability. That means if you take a period of 1 year or 2 years and try to see the thickness over a period of time, the differences, and arrange them, the variability in terms of quartiles, the lowest variability versus highest, it's seen that those who have high thickness variability, they tend to really do bad in terms of best corrected visual acuity. And this is a very important fact, because when two or more trials say the same thing, usually it is correct. So Cat and Ivan also found the same thing, and currently the newer trials of Hawk and Harrier also found the same CST variability. So this is definitely not good as far as neovascular AMD is concerned. Another thing now, as I told you, with the advent of spectral domain OCT, we are able to make out these individual fluid compartments. And this is actually a post hoc analysis of Harbor study, which tried looking at that over a period of time when we treat and we find the only IRF is remaining, or there is some residual SRF and IRF, or all have resolved, or there is only SRF visit which is present. And what they found, that definitely the worst is IRF. That means those after treatment who had intraretinal fluid are not good at all. So you don't want to tolerate any intraretinal fluid. And somehow they found that those who had subretinal fluid, they tend to do a little better. And that's the reason why the fluid study came. However, I'll not go in detail of those aspects, but must understand that these newer OCTs do give us idea about individual fluid component, and you don't want these fluids. So the current unmet need as far as neovascular AMD is concerned is less injections, less visits, less fluid on follow-up, and less central subfield thickness variations or fluctuations. And that's what is the need today. And 2019 actually sought, and 2020 saw two new agents which came into our armamentarium who tried to address some of these unmet needs. One was Brolucizumab, which was from Novartis, and Allergan came out with another drug called as Abicipar. However, both the things were submitted to FDA, and Novartis, the Brolucizumab, got FDA approval in October 2019. Abicipar had more inflammations, and the FDA approval was not obtained. They could not get a FDA approval. But I'm sure we will be seeing some modifications in this drug and see this also in the market in a couple of 1 or 2 years probably. So what is this Brolucizumab? So this figure, I think you all would be familiar, the antibody which is there, which we use regularly. And all these antibodies have two Fab domains and one FC domain. And what binds actually to the VEGF are these variable domains which are there. And more specifically on them, if you can see that circle, it's the CDR, the complementary related region, which is more targeted. It binds to the VEGF, and that's why we get this anti-VEGF effect. Now, 1 minute. Yeah. So what Brolucizumab, what Novartis did, they had some novel CDRs, which were again very specific for binding of VEGF, and they created another human scaffold, a proprietary molecule by Novartis, and they joined both of them to create a small molecule, 26 kilodalton, a very small molecule, which is very potent anti-VEGF action. That's a Brolucizumab. The key characteristics of this molecule is it's, as I told you, it's a small molecule, so definitely it will have more drug in a single injection. It causes a very potent inhibition of VEGF-A.
अभी तो अगले वीक हमारी होगी पहले खाली मेल्स की.
Yeah. Can somebody mute?
ना अगले बस आप मेरे चक्कर में अटके पड़े.
Dr. Sandeep Vijay, can you mute your mic, please?
अगले वीक के लिए बोल रहा हूँ ना. अगले वीक के बहुत.
Dr. Sandeep Vijay, can you mute your mic?
Yeah. So it causes a potent inhibition of VEGF-A. And as it's a small molecule, again, it causes a more effective penetration to the retina and choroid. So we may see a better effect. And it also gets cleared from the systemic circulation pretty fast. So these are the key characteristics of Brolucizumab. And the pivotal trial, which gave them a FDA approval was this trial, the Hawk and Harrier study. And these were actually in two different studies. Hawk was one study and Harrier was another study. And what actually they did was they compared it head-to-head comparison with Eylea, aflibercept. They gave 3 loading doses. So every month one injection was given. And we know that after 3 loading dose in Eylea, you can wait for 2 months and then give the injection. So at 16th week was a key period. At that time, if it was in a aflibercept arm, the injection was given. However, if it was a brolucizumab arm, assessment was done. If there was disease activity, they could continue it. They can give an injection even at 16th week. Otherwise, they waited and increased the follow-up to 12 weeks, that is 3 months. And then the arm which were in this 12 weekly, they continued with 12 weekly. However, there were in between interim assessment of activity. And if there were activity, it was reduced to 8 weeks. Aflibercept continued for 2 monthly interval. And then they tried looking at 1 year, the primary endpoint, and 2 years, the final analysis. So this is the graph which shows the change of BCVA in this 2 years time, the best corrected visual acuity. And if you see initially, both were doing pretty well. They increased. At the primary endpoint, again, there was similar, in the Hawk trial, they had 3 groups. They had 3 milligram, 6 milligram, and aflibercept. However, in Harrier, it is 6 milligram. And what we should more bother is about 6 milligram, because that's something which is commercially available today. And this is the outcome at the 2 years, the 96 weeks. And what it's nearly same. You use aflibercept or brolucizumab. However, what advantage here you are getting? You had select group of patients who could be maintained on this 12 weekly regime. Rather than 2 month interval, you are treating them every 3 months. So that was an advantage which is seen. However, again, there were some patients who were on 8 weekly also in brolucizumab. Definitely what was seen was better central subfield thickness. So the dark blue line which you see down is the brolucizumab, and the grayish one is the aflibercept. And you can see, we have seen whenever we have these spikes, which you are seeing with aflibercept, that does show that there is waxing waning of the effect of the drug, which translates in terms of increase in thickness and reduction of thickness, and which more or less is a straight line or very less fluctuation in cases of brolucizumab. So this is sustained over a period of 2 years. You could see a good effect, which was definitely a better drying effect as far as brolucizumab was concerned. This, as I told, had used the SDOCT, so they tried looking at all fluids and find that if you look at intraretinal or subretinal fluids, nearly a third less as compared to aflibercept, 30-35% less fluid at each time points. 16 weeks, that is our first one, where the 3 loading dose, and after that we had seen even at that time, there was a significant reduction or less in brolucizumab arm as compared to aflibercept. And then 48, 96, all the groups we see, there was less fluid in cases of brolucizumab injection. Not only this, but even sub-RP fluid was less. So all 3 fluids were less. And if you look at complete fluid resolution, you could achieve nearly, if you see, nearly 59 to 60% of them, the first 3 injections alone could dry the retina very well. Yes, even if you see in all the weeks, 48 or 96, more number of patients who were treated with brolucizumab had more complete drying of the retina. So definitely this study did tell us that intravitreal brolucizumab has a better drying effect than Eylea. This was a post-hoc analysis of the same study, which also tried looking disease activity, what you call a disease activity. They considered vision, anatomy, both function and anatomy, that is less than 5-line improvement, 5-letter improvement and presence of fluid, or they tried looking at all that, which was the one which were used in the Hawk and Harrier study. And actually, they did realize that majority of us, that's what we do in clinical practice. In AMD, we don't much go with the function or vision, but it's mainly the anatomical outcomes. The presence of fluid, which was more. The presence of fluid was an indicator for retreatment. And this was an interesting analysis which they did, a probability analysis, that if Brolucizumab 6 milligram patient, he's on this regime and he's maintained, the probability of maintaining this regime of 3 monthly interval once the loading dose is given. That means the first 3 injections are given. What is the chance that for first 1 year, he will be maintained on the 3 monthly intervals? And that's pretty high, about 56% in Hawk and 51% in Harrier. And they also looked into that if the first 3 monthly interval was successful. So you gave the first 3 injections, then there was no activity, and after 3 months you injected, probability of remaining on this 3 monthly regime in the year 1, nearly 85% of them. So how this translates into clinical practice is that after loading dose in year 1, hardly 1 or 2 out of 10 will need more than 3 injections. So that's something which is good. They also tried looking at 2-year follow-up. The probability of a Brolucizumab 6 milligram patient maintaining on 3 monthly interval after the loading dose. So if you look at that probability, about 45% of them will not return to a 8 weekly follow-up regime, but they will maintain the 3 monthly regime. And if the first year was successfully completed with the 3 monthly regime, the chance that they will continue with this 3 monthly in the second year was more than 80%. So that's something again very good. So in year 2, 8 of 10 will just need 3 injections. So this does give an idea that again, the drying effect which was seen seems to be a sustained effect with Brolucizumab. The safety profile, again, as far as Hawk and Harrier study were concerned, there were cases of inflammation, occlusions, endophthalmitis, which were reported. And Novartis gave a post-marketing update also that these events can happen with Brolucizumab. I tried doing some critical appraisal of this study, and one of the things which I found that especially Harrier had a lot of multiplicities which were not adjusted. They had patients who had more than 3 months duration. Baseline SRF was more in AFib arm, though it was not statistically significant, but in clinical sense, it was really something which could have probably given some effect what we are seeing. The other major problem which I saw was the risk of unmasking the treatment assignment, because the injectors were unmasked, they were knowing what they were injecting. And this study looked into only treatment name-wise, and there was no comparison with the other drugs which we use commonly, the Avastin or Lucentis, and it never checked the regime which we were using, the treat and extend, which we use in. And soon all these things you will be seeing, because a lot of studies are going on using treat and extend, comparing with Lucentis. All these studies are in pipeline. And once this study was submitted to FDA, FDA asked them to do another 6-month extension study, because the formulation which was used in the trial and what they planned to commercialize was a little different. So they did this 6 months follow-up study also, and that also gave the similar result of a good improvement, similar improvement. But again, this was not a comparative study, and this was after the study was over, that is 2 years. Just a couple of them patients, they followed them for 6 months. Now, we also have some real world evidence, and this is the work by Dr. Sadda's group. They published the initial 42 patient data of 60 injections, and they all had previous injections. So these were not treatment naive, and they found a good response in visual outcome, reduction of the disease activity. And in their series, they didn't report any inflammations. So let's see what is happening after 2019 October. Brolucizumab came into the market, and hardly 3-4 months later, there was an alert by American Society of Retina Specialists that one on February 23rd and secondly in March. They had about 11 cases, and then they said there were 21 cases of occlusive vasculitis. And that raised an alarm, and FDA came into picture. Even the Novartis did a lot of work. And after that, there have been a couple of reports, not many, I would say, because all of these are case reports, but there are about 4 or 5 cases which got published. And that gave us an idea to understand that what profile of patients will develop inflammation. So what was seen that majority of intraocular inflammation, they occur within 1 month of injection. So that's something you want to be a little more alert in the first month of your injection. And again, there is no specificity that it will happen in only treatment naive or previously treated, because even patients in real life who were previously treated with multiple anti-VEGFs and the Brolucizumab was given, they also developed it. So there is no specific preference that these groups will get more inflammations. And Novartis established this think tank, and they tried, which is currently working, and they're trying to answer 4 key questions. What is the root cause of these events? How can we characterize the patients at high risk? How can we prevent the adverse effect of inflammation? And if we develop these, if any patient of us develops these inflammation, how we should manage these patients to minimize the impact on vision. Now, how common are these complications? So there's a website by Novartis which constantly gets updated. And if you look at retinal vasculitis is nearly 3 in 10,000. Vascular occlusion is 2.3 in 10,000 injection. And overall, if you see, it is 10 per 10,000 injection. That means about 1 in 1,000 can have some form of ocular inflammation. I think that is the information. It's very, very important to tell our patients. So what pre-injection considerations you should do when you're planning injection Brolucizumab? Definitely no injection if there is anterior chamber or vitreous cells or flare. If even there are signs of old uveitis, anterior segment features, or posterior segment features of an active or a healed uveitis. If there is a prior history of inflammation following any other injection. So though we are talking about Brolucizumab, but there are a lot of literature, there are big series, nearly about 42 cases series published on inflammation, not infection, following other injections too. So if a patient develops has a history, don't give. An initial experience, it would be good to avoid in one-eyed people. Investigation, optional, but I would say it is important. If you have the facility to do a wide field retinal photography, you want to be really sure that there is absence of these posterior or intermediate healed or active uveitis. OCT, we have been in AMD mainly looking at membrane, but also try to look at the vitreous interface. Many times you can see these vit cells, and presence of that again is an indication that probably you try to avoid this injection. And definitely the risk that 1 in 1,000 can have inflammation should be included in the consent form. And more important is document all the negative findings. Many times, these things are not there. You have, unless you note it, later on you can be in a problem. So always better to note these findings and alert the patient of the symptoms. So tell him that if he has floaters, pain, pressure, or ocular discomfort which persists for more than 2 days, a light sensitivity, reduced vision, scotoma, vision loss, he should report to us. And once he comes to you, evaluate and look for these 3 conditions: intraocular inflammation, vasculitis, or a vascular occlusive event, both arterial as well as venous. And once you think that it is inflammation, it's like all other inflammations which we use. So first thing is we should think it is an infection, especially in our country. If there is intraocular inflammation, you see the cells flare, the reaction in the anterior chamber, definitely rule out an infection. And now if you have given Brolucizumab and he's having inflammation, definitely do a dilated fundus evaluation. If you can visualize the retina well, you can even do a fluorescein angiography so that you can make out any vasculitic patches. And based on the severity of inflammation, you treat with a potent topical steroid You can supplement with intravitreal and or a systemic steroid if required, but all the patients should be monitored regularly to confirm retinal vasculitis, which is many times associated with these injections. Once a person has vasculitis, definitely, as I told you, it can be both central involvement, it can even be peripheral location, or a branch can be involved. If it is central, it is more worrying because it will definitely affect the vision. Many times there will be vitreous haze and very difficult to make out. In these cases, you need to go ahead with your angiogram. If you have a wide field angiogram, better to do it. Otherwise, definitely do a montage or try to take peripheral sweeps. OCTA would be useful. And clinical features of perivascular sheathing, vascular leakage, or a disc leak will give us some idea about the vasculitis. And if they have that, treat exactly like other vasculitis, steroids. You can supplement with a steroid implant or a subtenon injection. And again, regularly monitor these patients because they may land up in a retinal vascular occlusion. And if you have retinal vascular occlusion, again, as I told you, it can affect artery or a vein. If you have arterial occlusion, you will see retinal whitening, cottonwood spots, cherry red spot. All these features would be seen. And what we get in a retinal vein occlusion, intraretinal hemorrhages and all hemorrhages would be seen. And these are the cases where definitely, again, there is a role of steroids, and treat with steroids, look long-term, assess for neovascularization, and consider panretinal photocoagulation if needed. So this is how the plan of management of patients who have this complication because of it. So it gives a fear that whether to inject this injection or not. And this is actually how you put the risk in perspective. So if you see the benefit is less, actually the central circle is of same size in both the diagrams, the risk of intraocular infection. It's only how you perceive the benefit of the drug in neovascular AMD. So if you see that you want a good outcome, which I showed you initially, you want less injections, you want less visits, you want a better resolution of fluid and a better visual acuity. Because many times I say that you get the poor outcome, the under treatment, over treatment once, anyway, he will lose vision. So definitely so it's the risk benefit ratio you need to take and decide to use this in your clinical practice. So how do we begin Pegenex? That's the name. And the good thing is Novartis has, as they did for Lucentis, having a special India costing. They have come up with a special India costing for even Brolucizumab. So select a compliant patient. You don't want a patient to get an injection and gets lost to follow up. Definitely your initial experience. This is again a personal opinion. So I'll try to use patients who are more compliant. Preferably, I'll try to use initially in patients who are previously treated, who are already not well responding, poor responders to anti-VEGF. Explain the risk-benefit ratios. Definitely do the pre-checks meticulously. Explain the warning symptoms in detail to the patient, and definitely try to evaluate them. Now in COVID times, we don't call the patient on day one. It's the tele-counseling which we are doing. But these cases, it would be good to see them first day. And definitely when they come for a monthly follow-up, our routine injection patients, what we do is, many people they don't even do OCT for after 3 visits they do. But at SN, definitely each visit we do a OCT. We need to do more than OCT. We need to clinically evaluate them, do a good slit lamp biomicroscopy, peripheral evaluation, and a wide field photograph at least to start with. So again, I'll come back to my original slide of unmet needs, and definitely Brolucizumab seems to answer some of these things, and time will tell us how successful or how useful it would be in our clinical practice. So definitely there are many, this is a conclusion side, many attributes of Brolucizumab which makes it a unique drug which has comparable safety profile except for the little inflammation. Definitely superior reduction of CST, robust visual gains, dries better, and definitely tries to address many of our unmet needs in neovascular AMD. So it has been approved now in nearly 41 countries and it's been used. And India, the market price is this. And it seems that it would be an important treatment option for our patients with neovascular AMD. Thank you very much. I'll be happy to take any
Thank you, Dr. Rajiv. Thank you, Dr. Rajiv. Very extensive coverage of the topic, understanding of the disease and the treatment options. May I request that we'll keep all questions at the end of the session.
Sure.
We have a few other interesting talks also. So if you are free, can we keep questions at the end?
Yeah,
Rajiv?
please. We can do that.
Thank you. Thank you.
Dr. Nitesh?
So,
Thank you. Thank you very much, sir, for wonderfully elaborating all the facts regarding anti-VEGF. Thank you, sir.